And good morning, everyone. I'm Dr. Ken Allen Williams, Chair of Medicine here at University of Louisville, and it's my pleasure to welcome you to Internal Medicine Grand Rounds. We are really pleased this morning to have a wonderful guest who will be talking about respiratory biologics as a case study for how to use high-cost treatments. And it'll be given to us by Dr. Matthew Rank, who's a professor of medicine and in the Division of Allergy, Asthma, and Clinical Immunology at Mayo Clinic in Arizona. But to give him a proper introduction, we have our own allergy person, the associate professor and head of the Allergy and Immunology Division here at University of Louisville. That's Dr. Tao Lee. Dr. Lee, will you give the rest of the introduction?
Dr. Williams, I am delighted to. I'm really pleased, to introduce Dr. Matthew Rank, who is an allergy and immunology physician at the Mayo Clinic in Arizona and is professor in the Mayo Clinic Alex School of Medicine. His research is focused on health services and translational researchers of airway and inflammatory disease. Dr. Rank is a national leader in our major specialty societies, including the American Academy of Allergy, Asthma, Immunology, and the American College of Allergy, Asthma, and Immunology. He draws on experience as a busy clinician who sees children and adults with asthma and other allergy immunology problems 5 days a week, and his experience in health services and knowledge synthesis research for this talk, which is focused on what is a very challenging aspect of his practice, which is how to approach the very high cost of medicines as an option when treating people with asthma. I'm personally going to be very keen on listening to this talk, given my own interest in clinical outcomes research. So with that, welcome, Dr. Rank.
Thank you, Dr. Lee. Thank you, Dr. Williams. Really appreciate the chance to be here and excited about this talk. When Dr. Lee reached out and asked me to come, I first was excited, and then when he proposed this topic, I was even more excited. So thank you. I'm really looking forward to spending some time with you all. So I want to start by just going over a few disclosures related to some of the other work I do. And I highlighted a couple in red. I'm going to spend just a minute on them so people are clear kind of what other experiences and other things I've been involved with. So the external organizations that are potentially relevant to talking about respiratory biologic medicines are a role that I have on the committee with the FDA Pulmonary Allergy Drugs Advisory Group. This group has not had any respiratory biologics come through our committee while I've been on it. So I think that's pretty low risk for conflict. The Allergy-Immunology Joint Task Force, this is a clinical guideline group that I work on. We are working on a guideline related to severe asthma. Biologics, respiratory biologics are certainly part of that guideline. I'm not going to be presenting any of that information. The guideline's not ready yet. Royalties, I have a small collaboration with laboratory scientists who are working on various different proteins as biomarkers for asthma. I'm not going to be talking about biomarkers for asthma today. And then research funding is primarily from NIH and primarily related to interventional studies or translational studies related to asthma. The final one, which is a study that's been funded but not yet started, is a comparative effectiveness or a pragmatic comparative effectiveness trial using respiratory biologics for patients with nasal polyps. Again, that study hasn't really started yet, but I am involved with it. So with that, let me tell you about what I hope to be able to cover for the next 40 minutes or so. So I want to kind of help define the challenges with access and affordability specific to respiratory biologics. I kind of like to use respiratory biologics as a little bit of a case study because I think it will probably have a lot of similarities to high-cost medicines that you all may use in your practice, whatever that may be. Second, I want to think about the perspective of the healthcare professional, of people like me, people like probably most of you on this in this talk, and how we navigate this system with the high medicine costs. Here's where I say and remind everybody, and Dr. Lee, I think, did a nice job explaining my background. I'm a practicing allergy immunology physician who most days is going to be seeing patients in our clinic, trying to give the best possible advice for some of these different problems we see. I'm not a healthcare economist or a public health expert, but I think being aware of some of these concepts, as I hope to show you, will help us do our best for our patients. The third learning objective is to try to predict a little bit or anticipate what might be coming next. Some of the things that are sort of in the mix here and how they may impact what we do in the next 1 to 2 to 3 to 5 years. And then finally, some actionable things, some things that we can take away as healthcare professionals specific to how we deal with high-cost medicines, again, using the respiratory biologics as sort of a case study. Now, I have just 3 polling questions, but I really like to do this, especially when I'm giving a virtual talk, just to get a sense of sort of how the audience is thinking, where you all are at with some of these questions that are related to this topic. And I'm going to start with this polling question. I'm going to read the question first, then I'll ask Jason to cue the poll. So just give me a minute to read it. What do you think is the highest priority for public health in the US? I'm going to give you these 7 choices: ensuring safe water and food, ensuring adequate mental health care, reducing chronic diseases, strengthening safety net programs, improving healthcare access and affordability, addressing the opioid and drug overdose epidemic, or preventing childhood deaths from gun violence. So just pick one. Again, there are a lot of these are all really important things. Jason, thanks for cueing the poll. Jason, I think the poll, at least in showing on my screen, is showing the next question, though.
All right, hold on one moment.
No problem. Thanks, Jason.
Yeah. Okay.
Right, looks good. Yeah, that's the old one. That one.
Okay, here we go.
Thanks. Perfect. Just another 10 or 15 seconds for people to play along. Thank you for being responsive to these polls. All right, Jason, can we close the poll? All right. So I think these are pretty tough choices, and I appreciate everybody's playing along and selecting some different choices. Let me show you what a recent poll showed. So this is Gallup and Emory-Rollins School of Public Health doing web interviews of U.S. adults just about 3 months ago, December of 2024, asking what public health priorities people have. And I want to highlight the first one, which is probably not surprising. People probably guessed the topic of this talk, which is related to affordability and access and how we deal with it as a healthcare professional. It's improving healthcare access and affordability really kind of rises to the top of all these really, really important priorities, I think, which says something about our system. And again, I hope talks about the importance of this topic for us. And kind of a little bit of as an aside, I kind of would have almost guessed this to be the case if we would have asked healthcare professionals who work in the system that this is a challenge. We interview and we interview applicants for an allergy-immunology fellowship training program at our place, and each year we try to do our best to have a low bias in how we ask the questions. So we ask the same questions every time to the same applicant. And one of the questions I had is, what do you think is the biggest problem with healthcare? And that was sort of meant to get a sense for how the applicants kind of worked with systems thinking. And about 70% of the residents, these are residents in training who are applying for fellowship, answered access and affordability or some type of answer related to that. So our residents who work in our system seem to think this is important too. I don't want to downplay any of the other 6 on this list. Those are also really important. So with that kind of focus and I think importance of this topic, I wanted to bring in an article that I came across that I thought was pretty accessible. It's written in the Harvard Health Publishing um, publication, and is written by Dr. Schmerling, who is a senior faculty editor for this journal, for this letter. And it was called "Why Do Your Prescription Drugs Cost So Much?" It was published about a year ago. I don't think it's out of date. I think, in fact, it's pretty current, even though it's 1 year old. And there were five main reasons why this physician thought medications cost so much. And then the subtitle of the article was, "How can you do something about it?" And then what policies might make a difference. So the five reasons that he thinks, at least, drugs cost so much are the drug maker's profit motive, the pharmacy benefit managers who play sort of an intermediate role in sort of the logistics pathway that ultimately deliver medicines to us, cost sharing for patients, legal maneuvers like extending monopolies and direct-to-consumer advertising, which, as probably most of you know, direct-to-consumer advertising happens here in the US, but there's no other country, or at least very few other countries that actually allow this to happen. So those are some of the big picture things that I wanted to start with. I'm going to do my second poll now, just to get a sense for how many of you in the audience are dealing with this, like Dr. Lee and I are dealing with this in our practice. So here's the next poll. Let me read it, and then we'll have Jason cue it again. Do you prescribe, fill, or help facilitate acquisition of medications that cost? And you pick the level that is your highest level, that costs more than $1,000 per year, $5,000, $10,000, $20,000, $50,000, or $100,000 per year. And I also included an option that says, "I do not know the cost of medications," because I certainly work with a lot of learners and a lot of other people that may not know what those costs might be. We're sometimes pretty insulated from that in our jobs. So Jason, could you open this poll, please? Thanks. And give a little bit of time for people to try to think about the medicines they work with in their practices. All right, Jason, can we close the poll? Show the results. All right, so yeah, it's really interesting. Thank you again, everybody, for answering. It looks like there's a lot of people in the audience who are dealing with some pretty expensive medicines, and are probably having the same challenges Dr. Lee and I are having. And then there's about a fifth of you who responded who may not be sure what the costs are, and that, I guess, wouldn't surprise me because often it's pretty opaque. Okay, so I want to have a couple more general concepts I wanted to kind of like review before I really get into the case study of respiratory biologics and some of the details. I like to think about problems or challenges in terms of different viewpoints or different perspectives and stakeholders. And these are the stakeholders who I think are probably most important in the story of high-cost medicines. Our patients, of course, us as healthcare professionals, kind of the perspective I'm trying to represent here during this talk, payers. So we give money to the government. We work for an employer, and those sort of serve as people who ultimately pay out some of the healthcare. Foundations who advocate, educate, fund research, pharmaceutical companies who discover, test, market treatments, pharmacies and pharmacy benefit managers who are involved in the logistics of delivering these treatments, and then overall perspective of societal good. And some days it may feel like you're sitting or standing in your clinic and you're talking to patients and you've had a high quality discussion. You think you have a pretty firm grasp on their diagnosis. You think there's a treatment that probably would work best for them and minimize harm. And you have a pretty good idea. And then it becomes the logistics. Maybe it's an expensive medication. Maybe the insurance company may have some very strict rules about whether they'll cover it if they do at all. And then maybe they'll cover it, but then it has to run through and figure out how we're actually going to get it coverage, but the copay may be very high. How does that work? So some days it feels like there's this gap between me and my patients, and some of these people, some of these different groups may be in the middle. But really, I think this is how we should be thinking about this. I really think all of these different groups can help us help our patients. And of course, once we help our patients and keep them healthy and keep them learning in school and sleeping, exercising, and all the things they need to be able to do, I think there's a pretty big societal good on the other end. So this is kind of the perspective that I'm taking when I'm thinking about how I can work with these different groups to help my patients. So now I want to get into the respiratory biologics as a specific example. And some of this will be some information that's a little bit specific to some of these respiratory problems for which biologics are indicated. I won't go too far into the weeds on those things. It's not the purpose of this talk is not to sort of teach or explain about some of those things. It's just to know enough to sort of show how this is an example of this challenge. So this is some of the additional information from the Harvard publishing letter that I initially presented related to why our medicines cost so much. And this is what can we do about these costs? So there were three things that really kind of stood out from that article. One was, do we really need to use the medicine? Can the insurance formulary help us find a lower cost alternative? And how can we use different discount programs and make sure we're getting the best possible deal? So the first one, I think the answers to do we really need to use these medicines are, how can we use guideline algorithms and perhaps even some associated cost-effective analysis to really make these choices? Shared decision-making, the concept of using the patient's values, preferences, having a high-quality discussion, considering all the options, and how can we have those conversations that help us come to good decisions about high-cost medicines? And then when we're using the medicine, do we really need to use that much? Do we really need to dose it at that often? And are there opportunities to potentially cut back, especially when somebody's been stable? And then can the insurance company help to find a lower cost alternative? Well, for respiratory biologics, as I'll show you, all of them have a pretty similar wholesale acquisition price, and there are 6 of them for asthma. So there's a little bit of competition for formulary positions, perhaps, and maybe there's more of it than I actually know about. But in general, it seems like the jockeying for formulary position has not been really a big move yet in this area. And then what about biosimilars? And I'll talk quite a bit about that, or a decent amount later in this presentation. And then the drug discount programs, this really plays a big role in people's copays for respiratory biologics, which often are zero. And so really understanding how these systems work and how it impacts the patient in front of you, and how some of those decisions may impact the whole system, I think are important for us to think about. So I'm going to start with guideline algorithms and cost-effective analyses. As I said, one of the things that I spend a fair amount of my time outside of patient care is on clinical guidelines. I've been working with that committee since 2016, and I think a lot about how we can take the evidence that's out there and understand it, interpret it, and translate that into what we should be doing for our patients. And so I'm a pretty big proponent, believer, and user of clinical guidelines when I'm trying to make the best advice for patients. Cost effectiveness analyses. I'm not a health economist. I'm not an expert in cost effective analyses. I spent a decent amount of time looking at these and trying to understand them. And when we do a clinical guideline, we certainly consider that as some of the extra information when we're doing evidence to decision or evidence to recommendation exercises. So just a little bit of a reminder about asthma. This is a common enough problem that most people on this in this session are probably familiar with what asthma is. It's a problem with the lungs which may manifest as cough, wheeze, shortness of breath, chest tightness. Can happen to anybody at any age. Tends to be a chronic problem. Can interfere a lot with life. It could cause people not to be able to exercise, interfere with work, school, sleep. Sometimes there can be pretty severe flare-ups of asthma that land people in the hospital. About 4,000 people each year in the U.S. die from asthma attacks. So there's some pretty, and about maybe 8 to 9% of people have asthma. So pretty common problem, and a problem, fortunately, that we have some pretty decent treatments for. Not all the time, but most of the time we can get a pretty good handle on this problem for our patients. And there are several, but this is the one I chose to highlight, the GINA 2024 Global Strategy for Asthma Management Prevention. This is a group that comes together every year, reviews the last year's evidence, adds it into the totality of the body of evidence, and makes recommendations on how we should manage this. And they divide this up into step-level care, where if somebody's having a little bit less trouble with their asthma, they may be able to use less medicine or less frequent medicine, and then it kind of escalates up through steps 1, 2, 3, and 4. And these are just some kind of shorthand terms for some of the inhalers. Inhaled corticosteroid has been the backbone of managing asthma for going on about 40 or 50 years now. And there are some bronchodilators like formoterol, for example, that can get combined with inhaled steroid. And if somebody's having a little bit of trouble, we maybe use a little bit of that medicine. And as we get to step 4, we're using more of that medicine. So kind of a simplified version of that, but it's really at step 5 where the respiratory biologics come in, which is why I'm highlighting this algorithm. So at step 5, we have, I'd say maybe about 5. There may be a few other options to consider. One option is to use even more inhaler. Another option is to use a different type of inhaler, long-acting muscarinic antagonist. A macrolide antibiotic is an option, leukotriene receptor antagonist, and then here are these respiratory biologics. These respiratory biologics were designed to disrupt the inflammatory pathways that are thought to be responsible for people with asthma. This includes blocking IgE, cytokine called IL-5, blocking a receptor for IL-4, which is common for both IL-4 and IL-13, and then blocking one of the alarmins that's thought to be important for asthma, TSLP. So that's kind of the context of where this comes in. And I think the general concept is sort of this tiered, stepwise care where these expensive medications may end up being sort of further down the line from some of the other options. Now I want to talk a little bit about cost effectiveness analyses. And this is not meant to be, again, completely focused on this part, but I think we need to spend a little bit of time understanding kind of what these are and how they work to think about these medicines. This is actually from 2018. This is when about 4 of these biologics were approved for asthma between 2015 and 2018. And so this group was commissioned. It's a Comparative and Effectiveness Public Advisory Council group. And it's the Institute for Clinical and Economic Review. And this was an evidence report on biologics, essentially. And these are some of the threshold prices that they came up with. Before I talk about the numbers, I want to explain a little bit about some thresholds. So the common unit of threshold in these analyses is called the quality of life year adjusted, the QALY. And really what it is how much would it cost in treating this condition to give the person 1 year of high quality health. And the thresholds that have been set are a little bit variable. So for example, in the US, and this is sort of almost like a willingness of society to pay type question. In the US, the threshold has generally been between $50,000 and $100,000 per quality of life year. And this is the reference that sort of talks about some of these different cutoffs from Annals of Internal Medicine from about 4 or 5 years ago now. In the UK, people put this at about $25,000 per year. And then in other countries, an estimate of what this might be would be somewhere around 140% of GDP per capita per quality of life year. And so there may be some variations on what this is from country to country. I'm going to focus a little bit US-centric here because that's where I practice, and I presume most of you do as well. And okay, so those are some of the thresholds. So in this table here in the lower left part of the slide are the thresholds that what these medicines would need to cost in order to be cost effective at these different thresholds. So for example, if we select 50K as our threshold, you would see that omalizumab, one of the respiratory biologics, would have to cost $4,700 per year or less in order for it to meet that threshold, and it's $9,000 or $13,000 depending on where you set the threshold. You'll certainly see articles where it says $150K per year for quality of life year, and then of course the medicines would be allowed to cost more if they were to meet that threshold. So a little bit of background there on that. And then this is, I think, my final polling question. A little bit long of a stem here, but let me read through it. So the wholesale acquisition cost, the WAC, is the listed medication price set by the manufacturer and generally serves as a starting point in negotiation with wholesalers. What is the approximate 2025 wholesale acquisition price or cost for 1 year supply of omalizumab in the US? So this is, some people may know this. I presume most won't, and I just want you to guess. And so this ranges from $2,500 all the way to $100,000 per year wholesale acquisition cost. Jason, please start the poll. Thanks. So Jason, why don't we close the poll? I think this is just a quick, people will guess fast. All right, Jason, I'm not quite seeing the results yet. Oh, there we go. Thanks. So it looks like a fair amount of distribution. Again, people just sort of guessing because most people probably wouldn't know. I would say if you polled people in my specialty who regularly use this medicine, most people wouldn't know. And the answers are somewhere in the 40,000 range. So these are the 6 respiratory drugs. The ones that are orange are also ones that are labeled for nasal polyps and chronic rhinosinusitis. I separate those a little bit because I'm going to talk about nasal polyps for a few slides here. So the wholesale acquisition cost, I kind of think it's like the sticker price. The sticker price is negotiated, however, and the prices that a wholesaler or a middle person might pay to acquire the drug is opaque. We don't necessarily know this information. Some of you in the audience who may work in these areas may actually know this. I don't know the information about what we actually pay for when we negotiate these. So all around $40,000, I think, is the point I wanted to make. How do other countries handle this? And I think this is really instructive because a lot of people in the US are trying to understand how others are able to handle these costs. In the UK, for example, United Kingdom, they have a group that really is tasked with doing these analyses, these cost-effective analyses. And that group is called the National Institute for Health and Care Excellence, NICE. Many of you probably heard about this group. They've been around for quite a long time. Here's an example of them looking at tezepelumab, which is the most recent approval. That's the anti-TSLP respiratory biologic. And then a little bit of information about the pricing. And I've pulled some of this into the slide. So what's stated is in the price that the UK states that the company says it's $18,768 per year in the US dollars. So it's about half of the price is what the sticker price at least is listed for UK. But the key part is the company has a commercial arrangement. This makes tezepelumab available to NHS with a discount. So this is the starting point. They negotiate and they have these thresholds that have to be achieved in order for them to even accept and then use that medication within their system. And so presumably the negotiated price in the UK for these drugs is below that threshold, which again is not something that happens in the US because the US until recently and still is, I guess, isn't currently doing this. The US does not have a negotiating sort of like system for figuring out prices related to cost effectiveness thresholds. What about our near neighbors, Canada? I'd say this is a similar type model. They have a group that will review this information. This also is the most recent one, tezepelumab. Here's their cost-effective analysis. This is the sticker price in Canada, so similar to UK, about half the price from US. And when they found at this sticker price, they estimate about a 1 million per quality of life year gained at that sticker price. So that's way above any thresholds that people would think is reasonable. And the probability of cost effectiveness at a willingness to pay threshold of 50K is 0%. So they kind of do all these different models, and they pick that for a threshold, and they said a price reduction of 95% would be necessary to hit our threshold. And so again, they're going to negotiate these prices with these manufacturers of these medicines when they try to decide if they're going to be used. I want to shift a little bit to nasal polyps, just briefly. A little bit of background on this problem. This is something I work with quite a bit in my went the wrong way here, in my clinical practice. It started off when I was in training, and I worked pretty closely with some ear, nose, and throat rhinology surgeons who are really interested in this condition. And I've been fortunate enough to have a lot of collaborations with our ENT departments over the years, kind of managing patients with this problem. So this is about somewhere between about 4% of the population has chronic rhinosinusitis, and maybe about a third to half of them also form nasal polyps. So this is like 1 to 2%. It's a far less common problem than asthma, but still a pretty bothersome problem. This is people often can't smell at all or very well. Their nose is blocked. They have this thick drainage that can really be bothersome. They might have facial pain, pressure, headache. These are quality of life, some pretty profound impacts on quality of life type patients. About 10 years ago, when these were first being studied, when respiratory biologics were first being studied with nasal polyps, I was sitting in a conference that was dedicated to chronic rhinosinusitis, and there was a speaker at the podium named Bob Schleimer. He was an expert in immunology of chronic sinusitis from Northwestern. And he said, I noticed these are kind of coming into approval and use for asthma. I wonder if these will ever be used for nasal polyps, because, well, nasal polyps doesn't kill people like asthma, doesn't land people in the hospital like asthma, is, a massive effect on quality of life. But is society going to be willing to pay for these expensive medicines potentially for this condition? And the answer ultimately 10 years later is yes. We have three drugs approved for this condition, and I have a pretty reasonable number of patients who take these drugs for this condition. So the society has a willingness to pay for this. So the algorithm for chronic rhinosinusitis and nasal polyps management is a similar sort of tiered stepwise management that we might have for asthma, but I suspect is pretty similar for a lot of other conditions where biologics or expensive high-cost medicines may be used. So at first, we confirm the diagnosis. We think about some other key factors that could influence some of the early decisions. We use some topical treatments, sprays, rinses. We think about the role of surgery in this condition. And then once we've kind of done all those things, if we haven't kind of gotten where we want to get, then we think about maybe using a biologic or even an alternative biologic if the first one doesn't seem to be effective. So that's kind of the algorithm part of this. This is just a reminder to go back and say, these three drugs at about these wholesale prices are the drugs we're talking about for polyps. Now I'm going to go back a minute to something else that I'm going to jump around a little bit. I'm going to use now nasal polyps and asthma together and go back and make a couple specific examples for nasal polyps. There's this concept of shared decision-making. And I think probably most people have heard this word probably hundreds of times before in clinical guidelines. So when we make a clinical guideline, if the evidence is not, if we're not confident in the evidence, or if there's some really important factors that may influence whatever treatment we're recommending, it often becomes a conditional recommendation, meaning if these conditions are likely in place, this really makes sense to use. If they're not, it may not make as much sense. And when there's a conditional recommendation, it often calls for engaging the patients in shared decision-making. So shared decision-making is something that I've thought a lot about because about 8, 9 years ago, I was asked by our medical school to teach the medical students about this. So I spent a lot of time kind of looking into this, thinking about and reflecting different models and how to teach this and how people can sort of bring this into their clinic. What it boils down to, and I think people know this already, is it's a process where we make sure our patients' values and preferences are considered. It's a process where the options are discussed and weighed together with the patient, and where we kind of work together to make a high-quality decision about whatever we're trying to decide on. And so I often hear people saying shared decision-making and writing it in guidelines, but I think when the rubber hits the road on this, it really just takes the time and the skill to be able to listen and then kind of have this negotiation with patients. That was a little bit of an aside. Let me get back to why this might matter. This might matter because when we're talking about benefits and harms, cost of medicine really fits into this discussion with shared decision-making. If you have two different medicines for diabetes, we think they're going to have similar benefits to manage their diabetes. The side effects may be similar. How much the patient pays for this may be a driving factor. Now, this is a little bit difficult to navigate, I think, as healthcare professionals, because we may not always know what that's going to be when we're having these discussions initially. Some of those things, like the insurance approval or not approval, the co-pays or not co-pays, the co-pay assistance or not being eligible for co-pay assistance, all those factors can sometimes make some pretty big differences ultimately in what the patient bears as cost. And in fact, as I've already said, people with commercial insurance who get prescribed respiratory biologics, they go through a process, insurance approves. They then are, depending on which plans they have, will have a copay assigned. That copay is often completely erased by applying for a copay assistance program that are essentially funded by the pharmaceutical companies who make those drugs. So the patient's cost may be zero. That I think in a lot of ways that from a healthcare professional standpoint, that would be great. So, okay, well, my patient doesn't have to pay anything for this. This medicine is likely going to be effective. I think the harm benefit ratio is pretty good. But there are consequences, and that's kind of how we think about this. Okay, the payers approve it, the pharmaceutical companies make it, the pharmacy benefits managers, they all make sure these medicines are delivered. Foundations are happy because their patients who they're advocating for are better, and we get societal good. But there is some systems trade-offs here. So this information, which I think is probably not surprising to anybody, comes from the Medical Expenditure Panel Survey. This is a survey commissioned by the government, run through AHRQ, and they're really trying to track costs of medicines in our system. In this case, this chart represents basically healthcare insurance premiums. And so for me, there's three different kind of stories you can follow or trends you can follow here. The darkest bar is if you have like a single person who's paying for their health insurance premium for a year. The middle is a +1, and then the lightest bar, which may be a little difficult to see, is the family. So I'm just going to follow the story for the family because that's most applicable to me. But you can kind of follow along here. So in 2010, a combination of what I pay and what my employer pays, maybe a total of about $14,000 per year for a health insurance premium. Now, this is just the premium. There are, of course, additional costs that we may bear throughout the year for healthcare costs, co-pays, things that are out of pocket that aren't approved, et cetera. This isn't the total cost of healthcare for a family in a year. But if you follow the trend from 2010 to 2022, it doesn't quite double, but it gets to almost $22,000 just for the premiums again. And you can see that that's a pretty rapid rise in just 10 years. And part of this rise has to be related to this system that we all sort of pool our money together to ultimately pay for these high-cost medicines. So it's kind of the general concept of insurance. But because the system pays a high cost for these medicines, these premiums rise pretty quickly. So I think people mostly know this. I just wanted to show some numbers around this. Next, I wanted to spend just a few, maybe about 5 minutes talking about how we use respiratory biologics. This is, I had a research grant about 3 or 4 years ago from the NHLBI to do some of these kind of research studies. And this is sort of the health research services research background that I have that I wanted to sort of bring just to get us to think about some of these other concepts. I think this is Again, probably why Dr. Lee asked me to give this talk was because I've been writing some of these articles. So the first thing is, when we have a high-cost medicine, are we using this resource equitably? And so with a lot of things in medicine, we suspected probably not. And so we did a study and found that indeed there are disparities in how these high-cost respiratory biologics are being used. People who are middle-aged, higher income, who have commercial insurance and specialist access, all are way more likely to get these medicines. And so there have been others from other researchers, Dr. Akinroye, Dr. Gleason, who have also published sort of similar findings in other data sets showing disparities in how these medicines are used. And the clinical implication is we really need to, as a healthcare professional, we really need to have these things in mind to help design and then be aware and try to break through barriers for people who aren't accessing these medicines because of these disparities. So again, probably not a surprise, probably something that's somewhat common across use of high-cost medicines in other areas. Then we kind of wanted to figure out, okay, so somebody goes on one of these, how long do they stay on them? How well do they adhere to them? And so the answers to those questions were, well, 6 months after somebody starts one of these, about half of the people are no longer taking them. And so that's interesting because these medicines really, if they're effective, would be meant to be used more over the long term. And then we wanted to know about adherence to medicines or consistent use of medicines because at least for asthma, and I suspect and I think knowing a little bit about the literature about other chronic diseases, adherence to medicines is a big challenge. It's something in our asthma clinic at the Children's Hospital, which we've been working on now for about 13 years. It's something we've noticed over and over again, how challenging it is for families and children to consistently use medicines. For inhaled steroids, the average use or the percent days covered based on how often people are filling their medicines, which is just the baseline. Of course, they could have the medicines filled and they could be sitting unused in their cabinets at home. It's about 44% of days covered for an inhaled steroid in this data set. And that result is pretty consistent across lots of other studies as well. So roughly half of people, the average person is maybe using half of their medicine that we'd be recommending them to use. That number jumps up to about 76% when we're talking about respiratory biologics, possibly because of, in some cases, this is like directly observed therapy where people come in once a month to get an injection. Now, a lot of these are at home. This number may drift downward a little bit. But we wanted to know that because we were struggling with kids and families who we were really trying to do all our tips and tricks for improving adherence to inhalers, just weren't getting anywhere. These kids were still missing 20 plus days of school. We're still in and out of emergency departments. And we thought, well, we've tried everything we can, we think, with trying to get adherence to be higher to inhalers. What if we switch to these biologics? Would we have a better outcome for the kids? And that is what we've done in some circumstances and found this to be something that kind of plays out where they may be more consistent with these injections that are much more expensive, even though they really haven't fully given the lower tiered options a full try. I suspect this plays out a lot in other diseases as well, where maybe some of the lower tiered treatments are less effective, or they have side effects, or they're just not consistently used, and you end up with one of these high cost treatments. More information about how we're using them. So we wanted to know what happens if you stop these medicines. You start them, and how do we decide when to stop? What happens when we stop? And we found that after stopping these medicines, you have about a 10% chance of having a pretty severe flare-up in the next 6 to 12 months. We found that people who didn't stop them, our control groups, had about the same risk. So the risk didn't seem too much different, which is curious because you would think that risk would be quite a bit higher when people would stop. We think this has to do a little bit with patient selection. We think that there were, especially early on in some of the data sets we're looking at, there were people who may not have really needed to be on the biologics in the first place who were being escalated related to a whole bunch of other factors. But there's still a lot we don't know. Then we wanted to know, could we predict which patients would have maybe some problems? So we built some models. We spent a bunch of computer power, collected a bunch of variables, developed a prediction model that had modest prediction capabilities. Not quite good enough, I'd say, for clinical use. And so we took all this information and said, well, some of these patients probably can stop biologics. Why does that matter? Because this is a high-cost medicine. If we don't need to use it, we don't want to use it. It's one of the sort of the tenets or principles is cutting back on use or stopping use and careful use. So we said, okay, so stopping biologics may be reasonable for many people, but we just don't have great ways of predicting who it might be best for. Then we looked a little bit harder at some of the kind of the applicability of the evidence related to biologics. So we had learned from reading about some of the inhaler studies that a lot of people who use inhalers in real clinical practice, like when you and I are sort of seeing patients and making these recommendations, these patients are a lot different than who enrolls in clinical trials. This, again, I think is something that goes across a lot of different specialties and a lot of different medicines. So we asked the question, of all the people that are currently using biologics for respiratory conditions like asthma, how many of them would have actually qualified to be in the studies that actually led to the approval of the medicine they're using? And as you might guess, it's less than 1 in 10 people. So 9 of 10 plus people who are using these drugs would have never qualified for the study that led to their approval because of various exclusion factors, because these are very strict. And this calls into question some of the generalizability or external validity of the findings from these trials. When we did the study, we also looked at the outcomes of people who didn't qualify or would have qualified for the study. And it turns out that their outcomes in these data sets were pretty similar after all. So this to me just is important for researchers and people who design studies to know. I think we don't do a great job of generalizability, especially in the higher phase like phase 3 studies, and it'd be nice to do a better job at that. This is where I'm bouncing back a little bit to nasal polyps, and I'm talking a little bit more about whether we could use less medicine. So this is the data. These are the data from the nasal polyp registration trials for dupilumab. This is now about 6 years old. And what they did was they randomized placebo to every 2-week dosing for the first 24 weeks. And then they took the people who were on dupilumab and randomized them and spaced them out. They kept people on Q2 or they went to Q4 weeks. And the 2 primary outcomes, nasal polyp score and nasal congestion or obstruction score, ended up being pretty similar between those 2 groups. So the way this information is interpreted is that Q4 weeks probably is just as good as Q2 weeks for most people. And Q4 weeks means you're giving like half of the amount of medicine. It's once a month rather than once every 2 weeks for the patients. And it potentially could save the patients, and more importantly, it saves the patients money potentially, or it may not because they may be paying zero, but it saves the system a fair amount of money. And so this is some advice that I've sort of incorporated to my practice, and I've been kind of talking about to other people, is we could probably back off to every 4 weeks for this expensive medicine pretty confidently. And for other biologics, there's a little bit less information from the trials, but we could probably consider decreasing the frequency by a week or 2 at a time until we hit about every 8 to 12 weeks, at which time the kinetics of these drugs, it's pretty much out of the system. If we can space them to every 8 to 10 weeks, they're still doing well, we can probably stop the medicine and expect them to probably do well. So those are some strategies that we use to try to cut back on medicines. Okay, I have just a few more slides I'd like to roll through, and some of this is to try to sort of get you thinking about your areas and how this may relate. So this is a provocative and interesting editorial that was written last month in one of our specialty journals for allergy and asthma. And the title of it was, "Should biologics be available for all patients with uncontrolled asthma regardless? Absolutely, and here's why." So this is like a little bit of sort of an angle of pharmacoequity, a little bit of some thoughts about cost effectiveness. And I'll tell you the main sort of thrust of their argument was we should simply just reduce the cost of these drugs to make them more available. A little bit about biosimilars, as I alluded to earlier in the talk. Omalizumab was approved, I think you may have noticed on the timeline, in 2003. That's 22 years ago. You'd think there might be some competition for omalizumab. Their substance patents expired. Their formulation patent is basically expiring last year or this year, depending if it's the US or in Europe. And so there are a lot of biosimilars starting to enter at least the system. And between now and when I submitted these slides originally and created them, about 2 weeks ago, there was an announcement of a US biosimilar for omalizumab that's been approved and will likely be coming within the year. So great, that sounds like it might provide some competition for some of these drugs and drive lower prices, but are biosimilars really a path to lower costs? This is not the first biosimilar story. There are others to learn from. In fact, this study from JAMA last year looked at 7 different biosimilars that have been introduced into market. And what they found, at least so far, is that the cost to consumers with the biosimilar introductions haven't really lowered their costs yet. I think there's still hope for this. Then, from a policy level, I think most of you probably heard about this pretty big splash. I think it was announced last year or so that the government was going to start negotiating for Medicare with pharmaceutical companies, lower prices for some of the medicines that they'd purchased from these companies on behalf of their Medicare beneficiaries. This is to start in 2026, so not this year, but next year. And it was announced that there were 10 drugs that were going to be part of this Medicare drug price negotiation program. None of these are respiratory biologics, but a lot of the drugs on these lists are ones that I'm sure people in the audience use a fair amount. And I'll just maybe point out some of the top line drugs. So this is an anticoagulant, brand name Eliquis, and the total Part D gross covered prescription drug costs for like a recent year was about $16 billion. So you can see that even if there's just a little bit of negotiation on price, there could be some pretty big impact on overall spending. I think this remains to be seen how this all plays out. But I think it's an interesting concept. And again, thinking about the UK and Canadian models, examples we showed for respiratory biologics, you can see how this might be an avenue that people care about. So I want to close with kind of that final learning objective like trying to summarize some of the actions that we can take as healthcare professionals, again, keeping with that perspective that I've really taken for this talk. So I think the first thing is to make careful diagnoses, use medical evidence, algorithms, and then have shared decision-making conversations with patients to use these high-cost medicines for our patients to their advantage. And then when there are patients who we really think would benefit from these medicines, advocate for our patients. Go take those steps that are sometimes time-consuming and frustrating, but do our best to make sure people are getting access to these medicines that have been developed and are effective and are maybe safer than prior options. Because if we don't do that, it's going to be a very inequitable system where just a small handful of people get access to these medicines, and a lot of people who may benefit from them don't. Serve on health system formulary teams. I didn't really talk about this, but a lot, but maybe I'll make a mention of it here. So our institution, I'm not sure if yours is like this, is a self-insured institution. So our employees' dependents are all self-insured through our system. And we have formulary teams that every time a new medicine comes on board, we have a group of experts that convene and try to decide whether to add it to our formulary and whether it would be paid for under our self-insurance. So I've served on various of these committees for our institution, and these discussions are enlightening and are important. And having a voice from healthcare professionals who are at the front steps of delivering healthcare, I think is important. Some of these committee members may not be seeing patients directly and may not understand some of those implications. So if you can be on these committees, you can add an important voice. Systems level advocacy. So some of the things I think I showed from a systems level today probably are things you've thought about before, but anything we can do as healthcare professionals can be often very impactful. I think performing research can make a difference. I think if we ask important questions, understand how these medicines are being used, identify inequities, try to fix them, I think that can really matter. And then again, the health policy discussion. I think that we as healthcare professionals often shy away from this. This is something we talk a lot about with our medical students. And I think there are some opportunities for us to make positive difference there too. With that, I want to stop and sort of go back to where I started. This was simply a case study of respiratory biologics. I want to ask the question, how is this story similar or different to what you all deal with in your world? With that, I really want to thank everybody for the chance to speak with you this morning, and I'm glad to take a handful of questions as time allows.
Well, thank you so much, Dr. Rank. That was a wonderful environmental scan for something that obviously is coming up. And I'm glad that my question for you was going to be around the IRA with the Inflation Reduction Act that included the legislation that would finally allow the United States to join the rest of the world in terms of drug price negotiation. As you know, we've been the only high-income country. It used to be said that New Zealand, but it was never true. They had a process. So we're out there as the only outlier. And that 10 drug list that you showed that was expanded a few days ago. There's another 15 that have been approved. And it was done initially by the Biden administration, but it'll be administered by the Trump administration. And the real question is, how far are they going to go? How quickly are they going to go? The doctor administered drugs would actually start in 2028, but that's really on the horizon. So I'm asking you to project it because you've been thinking about this. What is going to happen to us? Mayo Scottsdale is not a dish hospital, a disproportionate share hospital. Even though you have a large amount of underserved people every time I go there and I see them, but but not being a dish hospital, not having a lot of 340B pricing, which we do. And the real question is, are these two systems that are supposed to help, are they going to collide and take away our ability to help people with the 340B program because we now have more reasonable prices for the drugs?
Oh, yeah, that's a really, Dr. Williams, thanks for that additional context. That is probably a little further away from my expertise in understanding some of the dynamics of those programs. I think I guess if I were project forward and respiratory biologics, for example, became one of those negotiated drug prices, what I'd anticipate would happen would be, I think a couple things will happen. I think if enough biosimilars enter the competitive market, I think the prices will drive down, and these drugs will end up being used a little bit more broadly, and the prices will be a little bit better, and the rise in the premiums each year will be a little bit less. The impacts on hospital systems that either rely on markups of drugs that are administered by hospitals. So I'm thinking like some of the drugs administered in infusion centers, rheumatologic, gastroenterologic, hem-onc type medicines, and how those impact sort of the hospital's ability to remain solvent. Those I'm not as confident about what will happen there. I suspect there'll be pushback by lobbyists anytime any of those potential costs are eaten into from a hospital standpoint. And of course, certain hospitals really rely on those to remain in the black. So I suspect there'll be some pushback on some of these that impact that. Is that what you think too?
I think that's exactly right, and I don't see how we're going to be able to maintain the status quo. And I've never been a fan of pharma because we pay 2 to 3 times other developed countries' prices. I always view them as hurting our ability to help with health inequities. With the drug pricing, and my East End people can get it, and the West End people cannot in Louisville. So I never thought I'd be on the side in any way of pharma and all the lobbying that they're doing to try to get IRA to go away. Hopefully hopefully it has enough bipartisan and bicameral support to never go away. But they're pushing hard because they view this as the biggest fear to their profit margin. When I've met with pharma, they always say the same thing. If you take our money away, there will be no R&D. And my response is, the United States population has to pay for the R&D for the entire world. And they say yes.
Thanks. I think those comments are really helpful to really systems thinking type things that really matter.
My goodness. Dr. Lee?
Oh, I was going to say, well, go ahead, Dr. Lee. But I was going to also say I saw Dr. Furman with her hand up earlier. Did you have a question, Dr. Furman? Is Christian Furman. She's our the chief of our palliative medicine division.
No, Dr. Williams, you said exactly I was just going to talk about the Inflation Reduction Act, which you did, and so that's perfect. That's exactly what I was going to say. So thank you. No problem.
Thanks.
I know I think we're up on time, but I think we've got two questions in the chat, and let's see if we can get a quick answer to one or both of them. So the first one is from Dr. Timmons, and I'll just paraphrase. Dr. Rank, have you considered how AI tools might be able to use aggregate effectiveness data to help with pricing decisions and or equitable access decisions at a policy level? So I'm compressing that just a little bit. And then the second question is by Dr. Murphy. And I think it's more of a comment about and just I think corroborating with you that they're seeing issues associated, equities, and really hoping that that there's ways to address the pricing and accessibility issues. But back to you, Dr. Rank,
Yeah, thanks. I think the AI question is like a common question we're thinking about. How can we use that to fix some of the problems in healthcare? And I think there are some really nice opportunities here for us to be able to look at high quality data sets and understand kind of what's happening with some of these drugs. I think there are ways potentially to make decisions about who might benefit from these drugs using this information. Cautions are the AI only works as well as the data that's inputted, and if there are risks and biases within some of those different algorithms, we could even make things worse potentially. So it's really, I think we have to be careful with that. And then the second comment was related primarily to inequities and challenges. Tao?
Yeah. So I think it was more of a comment that they're just validating that what we are seeing in specialty care is also prevalent in primary care, internal medicine. So I think that was really more of a comment.
Okay. Yeah, I guess I would anticipate almost everybody who's involved in healthcare is dealing with the high cost of healthcare and the challenges with affordability and access. And I would expect primary care probably dealing with more than anybody. So I'm not surprised to hear that comment.